You know, the benefits doctors and patients get from an ongoing relationship include improved communication and a greater sense of trust. But a new study finds that when a patient is hospitalized, it's not very likely they'll actually get a visit from their usual physician. Haley Weldon filed this report.
When Betty Moore was hospitalized with pneumonia last year, having her regular physician come to see her eased a lot of anxiety.
Well, when I saw Dr. Sharma in the door, I smiled and said, "I am so glad you're here."
Betty and Dr. Sharma have what is called relationship continuity in medical circles, something considered to be at the core of quality health care.
It implies an affiliation between patient and their physicians, and it fosters trust between patient and physician. It improves communication.
But not much is known about how much relationship continuity is maintained when a patient enters the hospital, as Betty did.
There is very little written about continuity across transition, that is from outpatient to an inpatient setting. And this is the time that the patients are most vulnerable.
Dr. Gulshan Sharma of the University of Texas Medical Branch in Galveston and his colleagues examined the topic in a study appearing in this week's JAMA, the Journal of the American Medical Association. They found that in a national sample of Medicare claims, the number of patients who saw their regular doctor while hospitalized dropped by over 12 percentage points between 1996 and 2006 for various reasons.
Medicare reimbursement policies only allows one journalist physician to bill for concurrent care. So it is a financial disincentive for a primary care physician to see a patient while the patient is already receiving a care by a hospitalist physician. It also depends on how in close proximity you are to the hospital. And if you have to drive 45 minutes to see two patients.
The study did find that relationship continuity was higher for patients like Betty Moore, older and with other health issues.
The problems that you have increase with age, and I think it's very important to have a doctor that understands your age and your medical problems.
Haley Weldon, the JAMA Report.
Well, of course, the only thing that's constant in life is change, and to talk about that, I'm joined now by Dr. Lytton Smith. He is a family practitioner with a concentration in geriatric medicine. Dr. Smith, thanks for joining us here on the program.
Thanks for having me.
Now, you've been practicing medicine, we talked a little bit before going on the air, about 30 years.
Correct.
When you were first practicing medicine and you had a patient that was in the hospital for procedure, it was just part of your whole routine to go visit that patient, wasn't it?
Absolutely. We took care of the patient from start to finish. Most of my practice was built on emergency room admissions, taking care of the patient, and then following them after discharge. And I still take care of patients I met in the emergency room doing that this day.
So it was probably not unusual for you to miss a few family dinners as you were making your rounds at the hospital and seeing patients for a variety of different things, correct?
Absolutely. I spent many, many nights in the emergency room and in the operating room taking care of patients during my career.
I would have to think, doctor, that for, let's face it, when you're in the hospital, that's not a place you want to be. I'm talking about being from a patient's perspective. You've had a procedure done, or you're facing a procedure. There's anxiety. There's, in some cases, some fear, so to speak. You must have felt like you were a welcoming sign, a face of familiarity, so to speak, with all these unknowns running around the hospital, poking you and taking your blood pressure and all these things. You must have felt like you brought some peace to the patient.
I can give you one extreme example about that. When I was doing obstetric deliveries, I had a patient who I had to leave on a Friday afternoon in labor. I had a pre-trip away, and my wife and I went away. I came back Sunday evening to check on her just to see what had happened. She hadn't delivered yet. I walked in the room. She was scheduled to have a C-section. But I walked in the room. Her face changed dramatically. She relaxed so much, I delivered her in 15 minutes without a C-section. It was the tension in her face not having me there as I had taken care of her through the whole pregnancy. And that emphasized to me the concern that, and the ability we have as practitioners to develop a relationship of that intensity with the patient.
Well, you're so right what you just said, because we put so much trust in our physician. I mean, we're basically handing our lives over into your hands, and it's not only our lives. We think of our families, we think of our children. That's a great emotional burden that, unfortunately, you have to take on, so to speak.
Yes, and yet it's the commitment we have as practitioners to do that. And it's the great joy I've had in 30 years of practice to see patients in the office, hospitalization, then afterwards, and watch that continuum of care.
Well, let's fast forward now to current times, and of course we've got this evil Godzilla that's crashing through healthcare called the insurance companies, and of course these people are trying to cut costs everywhere they can. It's a tremendous burden, and one of the things that we're running across now is that maybe they don't think it's so efficient financially for the general care practitioner to be making these evening rounds, so to speak. Have you run across that in your practice?
It became an economic reality that's sort of what happened. It was easier for the practitioner to stay in his office and do outpatient versus inpatient medicine. It became inefficient to go and see 1 or 2 patients. Unfortunately, it's a mistake in terms of the patient care.
Well, I would have to agree with you. Now, how, from your personal perspective, and you've been, as we said, we've been practicing medicine for 30 years or so, how are you handling this new wrinkle, so to speak, in the industry?
Difficultly. I still see patients in the hospital on a social visit.
Okay.
Now, that's the methodology partly, although I still do take care of some patients who come to a hospital a little closer to me than my general hospital.
Okay. So you're making basically bonus rounds. You're going to see patients. You have a relationship with them. You probably know going in that you're not going to get paid for that visit by the insurance company. Yet your dedication as a physician, which I want to commend you here publicly on television for doing that, you're having to take this additional burden in your practice because things are changing in the industry. Is that an accurate statement?
I would say I don't think it's a burden. I think it's part of our commitment to the practice of medicine to try, when we can, to take care of the patient in all aspects of their care.
Well, Dr. Smith, what about your colleagues? I mean, I'm sure you're talking to each other about the various things that affect your industry, like we all do in our various industries. What are your colleagues saying about this situation as it develops?
Is variable. I think younger physicians sort of expect not to have to go to the hospital, expect not to have to take care of the patients in the hospital. And I want to clarify one issue, is the hospitalist movement is not necessarily a bad movement. That is that patients in the hospital, because of the intensity of illness, do need someone of a maybe a higher skill level managing the patient. But what should happen is we as outpatient practitioners should be participating in their care, not managing it moment to moment, but be part of the care, part of the team of care, so we see them as they go in and as they leave the hospital, so the continuum carries on.
Do you suppose, doctor, as time continues to go on, say 20 or 25 years from now, and people in our age group start considering retiring from practice, retiring from our careers, that the practice of primary care physicians visiting patients in the hospital will all but disappear?
I'm hoping not. I'm afraid that you're correct in that assumption. There's a movement called the medical home model. If that's practiced correctly, that we may reinstitute the primary care physician's role in all aspects of care, with truly managing the care in the hospital and out of the hospital in a truly model. I'm hoping that model will resurface and reinvigorate the practice of internal medicine and family practice.
Dr. Lytton Smith, a family practitioner with a concentration on geriatric medicine. He's also a member of the Orange County Medical Association. Dr. Smith, thanks so much for joining us on the program.
Thank you very much for having me.